Good afternoon, everyone. My name is Karen. Welcome to everybody joining us today from all different parts of the world. I am the practice manager for OCPHYS Consulting, Dr. Cunneen and Dr. Lingwood. I'm based here in Brisbane, and I am going to be your host today and just give you all a lovely warm welcome to joining us today from Brisbane. This is an interactive session. Dr. Cunneen will provide his presentation, but if you have questions along the way, please send them through the chat box and we will get started. We've already received a few questions from participants, and thank you very much for sending those through. Alternatively, if you come up with some questions after today's webinar, please email us at info@ocphys.com.au, and Dr. Cunneen will address those in the next few days. Today we are exploring the wonderful topic of mould in the workplace particularly, and how to be aware and the management of such a condition. If you have any need of assistance, if there's any technical problems, if you could let me know also in the chat box. I can't help with some audio and camera things. My camera will be going off shortly, but if you are having any audio problems, please do let me know. I'm hoping everybody can hear okay. I would like to welcome today's facilitator, Dr. Chris Cunneen, our co-director at OCPHYS Consulting here in Brisbane. Dr. Cunneen is probably known to most of you today. We have a very large audience attending today, and thank you for joining us. Dr. Cunneen has over 40 years of medical experience, and his specialty is in occupational and environmental health, as well as independent medical evaluations and permanent impairment assessments. He's done multiple worksite assessments, including seeing some of the workplaces with mould infestation. So I will hand over to Dr. Cunneen. The presentation goes for approximately 45 minutes, and we should have enough time to address questions as we go. All right, well, let's get started. Thank you, Dr. Cunneen.
Thank you very much, Karen. I hope you can all hear me. Welcome. It's a pleasure to be able to present and try and upskill people, as well as gain feedback. Always interested in education and learning. Today's presentation is on mould in the workplace, awareness and management, particularly from the employer's perspective. So under various state legislation and federally, it's also an issue that the worker is meant to be proactive as well as the employer. So it affects everybody. See if I can move on now. Thanks. So that's a brief bio on me. I'm a Queensland graduate. I've worked in a few states and territories. I'm a qualified occupational environmental physician. Well, for a few decades. I'm based in Brisbane. I work out of OCPHYS Consulting. We're co-director with Dr. Andrew Lingwood. We service certainly the southeast Queensland, as well as regional locations across Queensland. And as Karen said, I've had a little bit of experience with mould, particularly in the workplace. So the learning objectives for today, there's 4. One is identification of mould. That one there's probably self-evident. 2 is, I actually had written mould-free, but there is no such thing as a mould-free environment. That might be true in space outside of the Earth, but in any situation in Australia, unless you live in a bubble, is basically you can have low mould but not zero. It's ubiquitous. There is nowhere in the world, even at Antarctica and the Arctic poles, people find mould. And certainly in permafrost, where there's humans and where there's animals and where there's vegetation, there is mould. And to think otherwise is a fallacy. But it's all about the exposure levels and people's individual sensitivities. We'll talk about the health and safety standards. I mean, they're mandated legislated across Australia and in the various states and territories, and they're fairly consistent. And I'd like to say that certainly in Queensland, for WorkSafe Queensland, if you look at the website, they've got some really good articles on how to manage it, and there's also accessibility from the WorkCover Queensland website under the Office of the Industrial Relations. And similar access would be in other states and territories. So I apologise for the heavy Queensland focus, but it is what it is. And then it's about management with concerns. And the reason I put in brackets real and perceived, because probably more than half the ones I've been involved with, which I've been involved, there is actually no mould exposure. There might be a bit of dampness, but there's actually no mould. But people have perceptions that they're ill. And as we're all aware, perception is reality. So then it comes back to the employer and management and how they address that. So really, it's really a risk communication. And as Dr. Lingwood spoke in his the last OCPHYS presentation about Sandman, who spoke about the basics of risk communication, module 101. If someone's got a concern, you have to address it, whether it's real or not. It's their reality. I also would like to say, I forgot to mention, ALAR is not someone's name. It could be actually, but it's meant to be an abbreviation for as low as reasonably achievable. So it's about getting the mould level where it's lower than outside, and where basically it's not visible, and that if you do, and when you do remediation and you review and check in several months' time, the levels are lower than what they were. And the other thing is they're lower than they are outside, but they can never be zero. That's a fallacy and not based on reality. So what's mould? Well, it's a fungus. Basically, it's a fungus that grows in a filament. So it's a filamentous organism. It is related to yeast and mushrooms. So all of us, well, some of us maybe, will use them as a food source. Others get exposed to them anyway. It's ubiquitous. It's within every community across the world and every continent. And they're both indoors and outdoors. Hopefully there's more outdoors than indoors. There's about 10,000 known fungal species, but they believe there's over 1.5 million. So basically, we've only just touched the edge, and it's really the ones that are within an industry or a social community that basically we've looked at. But there's heaps of other ones, and we're fairly ignorant on them. So as we said, fungus, you get it in your yogurt. If you've ever had tinea, well, that's not strictly speaking mould, but basically it's a fungus. And if you air test and surface test most people's homes and cars and their bodies, you will find fungal spores, some of which may be mould. Not ones that are deleterious, but ones that basically we've picked up off a surface on our clothing, we've breathed them in, or you've ingested them. And pH of 2 in stomach acid doesn't actually kill them. They pass through and go down the bowel or wherever you defecate. So there's the issue of mycotoxins. Mycotoxins are secondary metabolites of mould. They have potential to harm individuals. They are not all harmful. Some of you may know the story, all of us should really, of penicillin and Fleming and Florey. Florey got the accolades. Fleming, who was the Australian colonial scientist with a big brain, he was the one who actually did the hard work and was able to recognise that when he put a petri dish out in a Scottish windowsill for 3 days, by accident, it was all serendipitous, a fungal spore happened to land on it because it was windy that particular weekend. And basically Fleming noted that there was a ring of dead bacteria, and that's a mycotoxin. So if you ever had penicillin or penicillin derivative antibiotics, you've actually been taking what is a fungal mycotoxin to kill bacteria that we use to change cell membranes to treat bacterial infections. Mycotoxins don't kill other bacteria. So anyway, they're in at the history lesson, but it's important because we use them, and our ancestors in previous societies knew that if you took moss off the north-facing trees at a certain time of year and put it on infections, some people got better. So that was a very early use within other societies. We just got rid of the leafy bit. And the big thing I'd like to say here, it's all about ventilation and exposure. So basically for the mold spores, the fungal spores, they don't like sunlight, direct sunlight, and they don't like fresh air. So the corollary is if you have a dark area, you've got moisture and no ventilation and no fresh air, well, the chances are you've got fungal spores growing, whether they're visible or not. So exposure, everybody's exposed to mold. There are people, patients, claimants, employees I've met, I do not get exposed to mold. Well, they must live in a separate universe. It's not the universe that 99.9% of us live. Certainly they may not get exposed to a lot of fungal spores, but I think there's 1 or 2 studies done about 30 years ago where most humans breathe at least 3,000 to 4,000 fungal spores a day. And for most of us, that doesn't have a deleterious effect. The issue arises is when basically it's high concentrations, it's sustained over a period of time, or if you're ill or have a compromised immune system or certain upper respiratory or respiratory diseases, then you may be at risk. But again, it's the basis of occupational hygiene and occupational medicine. Exposure does not equal disease. Certainly to get the disease, you have to be exposed, but not everybody who gets exposed gets the disease. And everybody, myself included, is exposed to fungal spores on a daily basis, but most of us don't actually come down with an illness or a condition. So how do we get them? Mostly inhale. Some people, the spore, you might be eating outside, there's been a breeze and a few spores have landed on your food. They're microscopic, about 1/100th of a millimetre. You're never going to see, or less, 1,000th of a millimetre, so you won't see them and you'll ingest them. And basically, unless you've got a compromised immune system, they won't go through the gut and into the bloodstream. I've seen a few people who've given me a slide that they get from 1 or 2 alternative health practitioners or fringe medical practitioners in Australia. And the thing is, they say, I'm growing fungi in my bloodstream. Well, the only people I've seen grow fungi in their bloodstream, whether it's mold or something else, yeast, is people that usually are immune compromised. They're usually 2 days away from death and they've got no immune system. They're usually in a hospital and it's palliative care. This is all a terrible story, but they have no immune system. Simple things that would not harm an otherwise healthy organism such as a human is basically toxic to them, and just tinea or any infection, not just fungal but bacteria, is going to be life-threatening. They've got no immune system and basically they'll be dead within the week. So that's pretty dramatic. And yes, they might have been exposed, but in those cases, they're the extreme where basically they're going to die. It's just a matter of from what, because they've got no immune system. So I'm not really focusing on that part of the presentation today, but as I said, healthy people don't have fungi growing in their blood, and if they do, well, they're not healthy. They're usually in a hospital. So as we said before, some employees, some managers too, could be an employer, experience ill health effects from mold. And they're usually in 3 categories. It's the allergic or hypersensitivity. Someone may have a previous sensitivity to mold that's developed over a period of time and they're unaware. They just know they get itchy eyes, they get a runny nose. Could happen at certain times of the season. And they may have been told it's allergic this, allergic conjunctivitis, allergic rhinitis. A small percentage of these are due to triggers, and the triggers for those people is actually the fungal spore. They don't actually get fungal infections. They quite often get a secondary bacterial infection, so you can have allergic sinusitis, allergic rhinitis as in a runny nose, or allergic conjunctivitis, and sometimes you get a secondary bacterial infection. You wipe your nose, you wipe your eyes, and other bugs come in and say, this is a party, I'm joining it. and they need treatment initially for the bacterial infection, because that can put them in the hospital and make them very sick. But the mycotic, which is my cases are fungal and mould irritations and infections. These are irritations and not actually infections due to mould. So they become sensitized. So a corollary for this would be someone like isocyanates, heavy metals, or two-pack paint. I mean, they're totally unrelated to mould, but I'm just saying they become sensitized to the particles. These people have become sensitized to the particles, and therefore once you reach a certain stage of sensitivity, and this in most people usually takes months to years, and they're usually diagnosed quite often a long time down the track, and that's not a criticism, it's just people don't think of mould. Normally there's, you know, pollen and heaps of other things around the dog, hair, dust mites and whatever, but mould is up there too. And that's an allergic response, and I've seen a few of those, and it sometimes requires a worksite visit, because if you see there's a mould accumulation and they're only sick at work, it could be due to a range of things, but certainly there could be an adverse exposure to something to which they become sensitized, just like people with formaldehyde in the air, or two-pack paint, or isocyanates, or some other occupational exposure. The mycotic infections, they're pathogenic. That's actually where the fungus, in this case mould, actually infects the person, doesn't just irritate it and cause inflammation. They're extremely rare, but not unheard of. I've probably seen about 5 in my lifetime of parking the ones in the palliative care ward who are dying from overwhelming infection due to no immune system. But in healthy people, usually not as healthy as they think they are, and they quite often have a problem with some part of their immune system. But the thing is, it can happen, and it's usually related to the dose. So if they, I've seen one where if a chap opened up a potting mix, 25 litres. It was a good brand. He didn't have any PPE. He basically took a big sniff of it with his nose sort of open at the level of the bag, and of course he inhaled some of the particles that were there, and over the next 2 weeks he got short of breath and actually ended up with aspergillosis in his lungs. So he got a lung abscess due to aspergillosis, but basically he breached safety protocols and essentially had a good snort of potting mix. I don't think it matters whether you're at home or whether you're at work. Potting mix, you need to have gloves. You've got cuts and scratches. Potting mix is full of lots of organisms. They're great in the soil and in the ground. They're not much good on your body or my skin. And in some people, if you've got cuts and scratches, they'll enter there and cause localized infections. And if you inhale them, well, then obviously it sometimes bypasses the nose and the upper airways and goes straight to the lung, and basically they're difficult to treat. I've seen someone who was cleaning up rat feces. There's always people in the dark in warehouses, and he was, not always, but mostly. And basically they had lots of drums full of some solvent. There was rats there. They hadn't got rid of them. So they were cleaning them up, and basically there was no P2 or P3 respirators used, and they inhaled, you know, lots of fecal particles. I won't say they inhaled the poo that was on it, but they inhaled particles from the poo, and rats carry fungi in their, apparently, like humans, it can go through. They had fungi, and these people again got aspergillosis, and I think the other one got a penicillinase lung infection. So again, it was, you know, basically they didn't follow the appropriate protocols, but they still was an occupational exposure, more through omission rather than intent. I've seen a couple of people with pre-existing history of allergy, but most people who have allergy to mould or other fungi aren't aware of it until usually down the track. It could also be you have pre-existing infections. You may have I've seen one chap who had a allergic sinusitis due to change of season, sort of like asthma, and he had asthma as well. But He had irritated sinuses and nose and eyes, and basically had a rip-roaring infection, rip-roaring inflammation in his sinuses. And then basically there was a visible fungus mold around a toilet, and the employer sort of dragged their feet in cleaning it. And mind you, he could have got the infection from anywhere, but at the end of the day, work may have been a significant contributing factor. So he got a secondary infection on an inflammation process unrelated to fungi, and got a mycotic infection, got a fungal infection in his sinuses, which requires actually antifungal treatment over a period of time. Whereas for the allergy, you don't need antifungals. Antifungals like greaseofulvin and other agents are extremely effective, but they come with significant side effects, and basically they are only given to patients who are usually systemically unwell, and basically usually in a hospital situation, or at least an infectious disease physician's assessment to start with, and they're closely monitored because they have significant side effects. And the third group is the toxic effects, which thankfully are very rare, and that's the mycotoxins. Will park penicillin, so it is a fungal mycotoxin, but I'm talking about where this can irritate particularly the lungs. It can irritate the central nervous system, and people get neurological, they can get abdominal, or they quite often get respiratory, where people think they've got asthma, but they've actually got a hypersensitive pneumonitis, where they've actually got inflammation and infection solely due to fungal mycotoxins, the substances, the metabolites they secrete. So, and most people don't get all of them. The vast majority are allergic. There's a small percentage of mycotic infections, and the vast majority of them are usually skin. They can be topical, certainly in the eyes, can be in the nose, the throat. Tinea is a fungi. It's not actually a mold, but I suspect all of us have had tinea at some stage. So basically, and that's usually other people's poor hygiene, or bathing in areas where you're not wearing a pair of thongs or something, because other people have shed skin, and when you shed skin, you quite often leave fungi. So employees at risk, we sort of touched on this already. So at increased risk, because we all get exposed to mold, whether it's at home, work, or the journey, is really if you've got a known allergy, and that number is very small. There's no one test that'll tell us that you're, from a pathology blood test or otherwise, that'll tell us that you're allergic to fungi and mold, but basically it tends to be an evolution, and they realise they've got an allergic conjunctivitis with the eyes, or it could be sinusitis or nose, or even some asthmatics who have multiple triggers, of which most aren't known. And in some people, they either have a mold sensitivity, or they'll develop one. It's just like house dust. House dust is actually, or dust mites is actually, if you read the articles, there's dust mite poo, so that you inhale. And the thing is, it's the allergic response to the little fecal droppings that give rise to the responses for dust mites. So thankfully we can't see them most of the time. The airways, it's really, people tend to divide it in the upper airways and the lower airways. The upper airways are ear, nose and throat, so you're talking, and the eyes, so you're talking about ear, nose and throat. And we sort of draw a line where you're below the trachea, and that really becomes the lungs, and that's to do with asthma. So I sort of divide them by convention. As I mentioned before, sinusitis, people tend to forget about that. Oh, I've seen a few people who've had fungal infections in their ear from work. They work in a moist environment. There's not a lot of ventilation. They put their finger in their ear, and if you do it often enough and irritate the skin and get a breach, sometimes you'll get a bacterial infection. Other times you'll pick up a fungal spore. The fungi goes, this is great. I'm going to have breakfast, lunch and dinner for the next few weeks. And there you are. You've got, a fungal infection in the ear, like kids get when they go swimming. Some are bacterial, some are fungal, and some are a mix thereof, because where the fungi are, the bacteria like to be, and where the bacteria are, the fungi like to be. They're not socially destitute. They're quite happy to share the host, you, me, and everyone else. People with an impaired immune system. So I'm talking about people having cancer that are undergoing chemotherapy or still on agents to keep them in remission. People with HIV or other significant viral infections that have a compromised immune system. And certainly anyone who's had an organ transplant has to, unless it's from a twin, an identical twin, will need to be on anti-rejection agents for the rest of their life, which dampen down their immune system, and they're at risk of overt infection from diseases that you and I wouldn't normally become symptomatic. And of course, those at the ends and the beginnings of life, the extremes of life, so infants, usually particularly those in the first 3 to 6 months, and the elderly who also, they've got an immune system, but for some of us, as we're getting older, the immune system becomes less proficient. I thought I'd mention chronic lung disease as well, because that is an issue. It's not just picking on smokers. We've got to about vapors these days, haven't we? But it could be, long-term marijuana smokers. It could be someone who's had bronchiectasis or a family history of rheumatoid lung or something. But in this society, it's certainly chronic obstructive pulmonary disease. So looking at emphysema and bronchitis, or someone who's got chronic infection who may actually not be a smoker, and certainly they've got compromised airways. It doesn't take much for them to get inflamed and then have an infection, and certainly I've seen a couple of those where they've got emphysema and basically they then get a secondary infection, most commonly bacterial, and may have an empyema, which is the fancy name for a bag of pus within your lungs. Doesn't sound good, doesn't feel good, and not have anyone who liked it. Whereas chronic bronchitis is where you cough up pus from your lungs at least 3 months a year, and that's challenging as well. And then you've got the skin infections, because not everybody involves the airways. They may have a breach or a small cut. It could be a micro cut that you can't see. And the next thing is like nail infections, paronychia. I mean, we've all had those at times where you get an infection around the cuticle or around the margin of your fingernail, not being rude, just holding up my index finger, and you get a nail infection, and it could be on the toes. And quite often, a lot of those are fungal. There's moisture, it's dark. Some people don't wash their feet or their hands very often, so the bugs have a field day. And basically, there's lots of dead skin, so you're satisfied, it's warm, it's got moisture, it's dark. Might keep their hands in their pocket or in a pair of gloves, and basically there's heaps of dead skin, so the bugs, whether they're bacteria or fungi, mould, have a field day, and seen quite a few of them. It's hard quite often to relate that directly to work, but in some cases it could be if your hands are wet and immersed in moisture, that may be a reasonable significant contributing factor. So talking about this, as I said, more than 10,000 identified. We could spend a year talking about them, though I'm not a subject matter expert. I'm not a microbiologist specialising in fungi. I just picked on the 5 most common ones. Aspergillosis, you may have all heard of. It's not uncommon. It's out there, and some of us, if you swab us, may have 1 or 2 spores on us, but that doesn't usually lead to disease. Cladosporium's another one, penicillin, obviously related to penicillin, as you said, with the mycotoxins. Strachybitris. It's the one that classically produces dark mould. I mean, they all have the potential, but it's the one, if you've got dark mould, doesn't mean you have it, but that's the one you've got to be careful of and certainly follow up. And Alternaria is also up there as well. So I just got a slide on each of them. So these are fairly common. If you swab anyone's home, car, push bike, kids' toys, or worksite, particularly where you eat, and the toilets, you'll find these are quite common. I've actually put a slide of Aspergillus there, and there's the molecule. You may have heard of aflatoxins. It produces aflatoxins, which are good for some people and bad for others. So basically, it's found if you pick up some of the litter around your garden, and get it analysed, you'll find in dead leaves, compost, and decaying vegetation, aspergillus is there. These mould are really important because they break down all the vegetable matter, whether it's in a rainforest or whether it's in your backyard, or whether it's a leaf you've got in your shoe that you've been carrying around for a year and a half. Is basically they are nature's little rubbish people that converted back to the basic proteins and compounds, so that basically the next generation of vegetation has something to grow in and a food source. So they're essential, but you just don't want them on your skin or in your body at a certain level where they cause sensitivity or illness. So they do have health risks, particularly, it's not uncommon, not that mild respiratory infections are common, but I'd say at least 20% of them are probably due to this particular mold. And certainly if you become allergic to it, like people become allergic to two-pack paint or penicillin, well, maybe I'll pick some other tablet, non-steroidals or something else. Then basically, once you're exposed, you're sensitized, then basically you may struggle to work in that environment. So you may need relocation, or you may need to be redeployed or find another employer. And certainly for some asthmatics, there are some known triggers. Not all asthmatics by any version. There's 1,000,001 triggers for asthmatics, and probably 80% of them we are aware of from a medical or health perspective. So Bladdersporium, yeah, it's found outside. It's a bit more organised. It likes to be around plants and wood. It's also common inside. If you've got carpet at home, regardless of whether you have it industrially cleaned or you vacuum it every day or once a month, you will have this particular organism there. Probably not in a high concentration. If you've had grandchildren, children, dogs, cats, or someone wee or poop on your carpet, it's highly likely where that's happened, even if you've cleaned it up. That's going to be a good source point because there's lots of nutrient there for them, even if it's only microparticles. It's dark, there's not a lot of ventilation, and it's usually humid. And the health risk for this is really allergic response, again, to the upper airways, the eyes, the nose, and possibly the lungs. Could be where it's a allergic, because asthma is an allergic reaction to an external trigger, and we just call it asthma. It's the name we use these days. 100 years ago it was called chronic allergic bronchitis, but we now call it asthma, which is where you trigger up airways to some allergen or multiple allergens if you're unlucky. So fungi may be one of those. Thankfully not terribly common. Or if you pick your skin, you've got holes in your skin and you're exposed, it likes to. So that's one of the ones. If you're running around potting mix and fixing up your herb garden or something, you should wear a pair of gloves. And even a P1, though, the hole in the mask is a bit like a basketball hoop, and putting a ball bearing through it, the size is all wrong. That's why you should have a P2 or a P3. I don't see too many people with potting mix at home wearing a half face or full face P3, myself included. I just usually don't take a breath when I'm around potting mix. So I don't want it in my lungs. It's fine on my skin, but not on my lungs. Next one is penicillium. Yes, obviously related to the mycotoxin that we use for medical reasons. It loves water. So if you've got a water damaged building, whether it's due to rain, poor drainage, leaking eaves or something, or roof, as opposed to where you've got a damaged toilet or you've got a tap that needs to be resealed with the and certainly it likes wallpaper and carpets. It's a frequent flyer too, and they're fairly similar. You get allergic responses, irritated eyes, irritated nose, fullness in your face. There's not infections. This is just where the immune system basically collects and you get a pooling of fluid, so you get itchy, sore eyes, runny nose, You could have, where your sinuses feel full and they might have some fluid, but it's not actually infection, but it's just waiting to get infected for all the wrong reasons. Certainly can irritate known asthmatics and, as you said, sinuses. So yeah, don't go sniffing your carpet, particularly if one of the grandkids has been around. 4 is Strachybotrytis. Yeah, it's known as black mold. I mean, they all can cause black mold. This is the most bizarre picture I could see, but basically, it likes being in organic compounds that have some rigor. So it likes paper, it likes straw, it likes walls, particularly, but they've got to be damp. All of these organisms need an environment. It's just like humans, we've got to be clothed and fed. We need to keep warm or keep cool, depending upon the external temperature. And basically, to nourish us, well, these are organisms too. And as you can see, they need poor ventilation, stale air, they need moisture. No moisture, you can't have fungi, particularly mold, if you don't have moisture. There's 1 or 2 cases on record, but I think basically that they're able to find some moisture there. And certainly if the drywall is no longer dry, well, that's a good medium. And remember, for some of these, what you see on the outside is a bit like an iceberg. It's only a reflection of the fact that it may be a lot more inside. So again, it can be the allergic ENT side. It may lead to infections. This one, if you're compromised, you've got poor hygiene and your nose is way too close and you inhale it, well, it like aspergillosis, likes going to lungs and having a field day there. And once in there, it's very hard to treat. It is a cause of chronic fatigue state for some people, and certainly it likes going for a wander in the immune system if people are severely compromised, and it may give rise to headache and confusion and other things, as well as abdominal pain. And the 5th one, Alternaria, well, it's a bit more basic. It likes soil, it likes plants, and it certainly likes if you bring it from outside, because that's where most of them come from. Most of the fungi in the human habitations have all been brought from outside. Humans are very good at doing that, regardless of how obsessively clean you are or not. We all bring some in. Whether it's visible or not remains to be seen, and certainly they like showers and toilets and damp walls. So again, the moisture. And then yes, there's, as I said, there's allergies that can irritate people with asthma. Not too many examples where it's actually caused allergic asthma, but it usually irritates those with pre-existing asthma and becomes another trigger. And you've got hypersensitive pneumonitis, which is like one of the more severe allergic reactions, where basically you haven't got asthma, you've got where the actual, it's not the airways, it's actually the lung sacs and smaller areas where the oxygen goes becomes hypersensitive, and that can be deleterious to your health and difficult to diagnose. It's quite often a diagnosis that's made somewhere down the track, and someone else who has some insight into not only infection but occupational exposure puts all the points together. So the mold types, as you said, it's important to understand there's various types. I've just touched on them. They have risks, and that basically if you have in the past, or if you in the future as an employer or an employee undergo a air or surface sampling, you quite often find those. The fact they're there doesn't mean that you're ill. Humans are pretty good at, like a bad smell from a business next door quite often makes the staff in adjacent businesses feel ill. And that's the old hindbrain in humans, identifying, bad smell with bad experiences, and usually rotting, decaying things, and basically adverse experiences. So it's sort of, coded into humans, some more so than others. But basically, you can identify them, and then basically it's a matter of how you remediate and control it. 1, so it doesn't happen again, and 2, so that your staff have confidence that the building is safe and that the management's taken them seriously. So the causes of mold, we've sort of touched on this. There's really, it's a 4-pack. So you need all of these. you need moisture. If you haven't got moisture, they're not going to grow. So here's basically where you can see someone's house and they've had moisture, and basically, wood rot, you know, melamine and such stuff, and or wheat bix. If it's chipboard, it swells, never the same. So you may have a leak. It could be from a gutter. It could be from a pipe inside the wall, and quite often it is. The thing that people tend to forget is the ceiling. I've seen quite a few places where I've gone in and they've cleaned everything, so visually it's not there. But there's been no air testing. You do the air testing and you know that it's coming from the air conditioner, where they probably have a shallow or area of impaired ventilation. Because if you've got, as I said at the start, lots of sunlight and lots of fresh air where there's air movement, they don't tend to stay. The spores get dispersed somewhere else, hopefully not in a high concentration. So basically air conditioning, heat, ventilation and air conditioning is important. If you've got that in your roof and you haven't had that looked at, well, then basically you're kidding yourself that you've remediated it. And if that hasn't been recommended or been explored by the professionals who are assessing it, they probably haven't done their job. But most of them are well trained, thorough, and they'll recommend that. It may cost time and money, but at the end of the day, ensuring staff are well and don't have concerns, whether they're real or perceived, is extremely important, particularly in a society post-COVID. So basically, we talk about moisture, humidity. People think they're more common in summer. Well, actually, they're more common in winter, because basically people quite often turn the heat up. So therefore, you've got higher levels of not so much moisture, but higher levels of warmth. They quite often, the air conditioning could be 20 or 30 years old. So therefore you'll get spots that basically don't ventilate well. And if there's moisture there as well, it's a good recipe for mould and fungi. And it's like humans who get tinea and other fungal infections, not mould, quite often get them in winter because they wear enclosed shoes, they wear thick socks, they may wear them for more than one day or longer, and basically they rug up. So therefore the skin stays warm, stays moist. There's dead tissue, organic matter, and therefore people get them in their fingers, they get them in their toes, and in their armpits, under the bust, and certainly in the genital region. So humidity we've mentioned. Temperature is important. As we said, certainly you can get it in summer, but actually you see the better ones in winter because people don't think they happen. And certainly warmth is a big factor. And then it needs substance to grow in, so it needs organic matter. So that could be your skin, my skin, could be wood, paper, or fabric, particularly if it's cotton and not synthetic. So how do you test? You've got to have a visual inspection. That's a good place to start. That doesn't mean that people are ill, but sometimes you'll find some of your staff or your co-employees, they believe that if they've been exposed, they're ill. That sometimes means there's a psychological component and there's a stressor, but it's still, you can't ignore it. You've got to take it on board and assess it and manage it appropriately. So these should be done on a regular basis. It should be cleaned. This is where really the cleaner or the people who keep the building hygienic are involved. And as I said, heating, ventilation, and air conditioning systems are a big factor here. The big thing to bear in mind is you may have mould, but you may not be visible. Could be around a corner, could be hidden by the wall, and there's actually a duct, but the duct doesn't actually have any build-up. But 2 feet away, you've got 15 inches or 30 centimetres of it. So you can't always go on what you see and can't see. Common areas are usually damp, humid. So you're looking at bathrooms, you're looking at basements, kitchens, or where basically you've got a defective air conditioner or a where you collect water. Some businesses collect water and they've got a hole and there's a leak, or it could be there's a dam effect because it's not totally level. And as I said before, you've got to remember ceilings. If you don't go into the ceiling, you quite often miss where the main area affected is. There's odour, invisible. Some people have extremely good nasal capacity. Their olfactory bulb is great and they can smell it. I think so. One or two companies have dogs that can do it, but that's usually when it's not visible. Sometimes I've got to look in the ceiling as well as take part of the wall off. But yeah, quite often it's visible. If you get a musty odour, it may be signs, if it's not visible, that you've got mould infestation. There are moisture meters, and I'll put a photograph of one there. That basically tells you what the level of moisture is. And you know, for most of these, if it's at 35.6, well then basically it's way above what the product manufacturer has. Gives you a reading, and the people that do this on a regular basis, the occupational hygienists, have all this equipment. You can have high levels and you can have moisture, but that doesn't necessarily always mean. Some people have moist walls, rising damp, particularly in you know, the Melbourne and Tasmania, or overseas in the Northern Hemisphere when it's the cooler months, but that doesn't always mean they have fungi. It may mean you've got a leak and a potential problem. I'd move air sampling is important. So that basically is where you have a monitor that's set up. Could be in a kitchen. You'll have to isolate the area. So therefore you take a real-time sample, and it needs to be in a contemporaneous time period. So not like 6 weeks later after you've cleaned it. You probably should do it at the time. And then after it's been remediated is best practice. So you then measure the airborne air quality, and then you send it off to a lab where they're able to certify what bugs and give you percentages and how many. And that's important because that then basically will sort of tell you people are claiming I've got this and that from the mould exposure, and basically it's aspergillosis and it doesn't cause that as a adverse effect. Well, it's unlikely to be due to that particular exposure at work. It could be due to exposure at home or somewhere else. So we do sample testing as well. So that could be tape or swabs. And this has got a bit of both. And you collect it and then you swab it and then put it in a container and send it off to the lab. And that gives you sampling as well. And as I said, if you tested most people's homes, we'd all come back positive with something. Doesn't mean the home's sick. It just means that we're humans and these bugs are ubiquitous. So they also, what I didn't flag there is they test outside. So if you're testing a building, you always do outside, because in an ideal situation, the levels within the building will never be zero. Hopefully they're low, but they should always be lower. If that's outside and that's inside, and the inside's at a higher level, that means someone's been bringing it in. But in the ones that have been remediated and are safe for the workforce, they'll usually have some level, but it's always considerably lower than what's outside, and it should reflect the bugs that are outside around the building and not 4 streets away. So bulk sampling, that's basically if you've got a wall and you're not sure, well, sometimes you'll take a sample of that and analyse it rather than in addition to air and surface sampling, and can also give you an idea of how extensive it is. I've only seen it done a few times. So you get external help. There are various companies, usually approved inspectors at state and federal level, certainly have hygienists, and basically they have appropriate qualifications. I've seen 1 or 2 reports from various businesses where they're fly by night and they got their qualifications from some university in Azerbaijani or something. So it wasn't worth the paper it was written on. Nothing against Azerbaijani, but you know, it wasn't a valid qualification. They may have worked as a labourer and then basically have read a couple of books, but basically there are appropriate qualifications, and you can certainly ask them. Most people are only too happy to show you how well trained they are, how knowledgeable they are. So then after they've done that, you then should receive a detailed report. There should be a remediation plan, and then after the remediation plan's been involved, usually by the company that's done the assessment, then usually at a period 2 to 4 months later, it should be rechecked. I know a few companies that have declined to do this because of the fact it was going to cost them money. But, you know, they have the issue of where the staff said, is it better? So if you got it in black and white, it's much easier to say, well, this is what it was, this is what we did, and this is where we are now. So that keeps everybody happy. And certainly that's encouraged as best practice by codes of practice and certainly by the Work Health and Safety Act 2011 for Queensland. So basically it's about being proactive, accurate, detecting it and timely and remediating it. So what I'm saying here is manage the risk. If you don't do that, you're not managing the risk, so expect to have problems. And as I've said, probably half the ones I've seen, there is no mould exposure that's critically significant. But the thing is, it's the perception that there was mould exposure, and for some people that may lead to a workers' comp claim, but it may be a psychological or psychiatric one. So the health effects, we've spoken about the allergy, and where if you've got a bad enough allergy and that's a bit of inflammatory seep hanging around, well, that's a good medium for the bacteria to come in and have an effect. And I've seen a fair bit of that where some doctors have said they've got fungal infection, which is really uncommon in the sinuses and the eyes and the nose. But they may have inflammation where they've got an allergic effect. They get bacterial, and then if you culture it, quite often it shows the bacteria because the fungi have gone, but they've sort of left the area swollen and inflamed. You can get infections, be it from the skin, the nails, the hair, through to ear, nose and throat, the sinuses, the chest. So you could get bronchitis, pneumonia, and some people have empyema and bronchiectasis, where you sort of have chronic pus collections, none of which are terribly pleasant. Not very common, thankfully. The toxic reactions we spoke about with mycotoxins, that particularly in those that are immune suppressed, or in some people it may lead to immune suppression, and particularly the disease I mentioned before, hypersensitivity pneumonitis. And it can make existing asthma or cause asthma and certainly lead to empyema. I'd mention the thing again, as I said, I've never seen a worker who's been vertical, who's not in hospital, imminently unwell and probably die in the next 2 days with mould in their blood. I've seen a few people who've shown me photograph. The funny thing, it's always the same photograph out of a pathology textbook from about 40 years ago. So I think basically it may be very fringe and inappropriate medicine there, but because basically if you've got fungi growing in your bloodstream, you're not doing very well. I mean, if people have bacteria growing in their bloodstream, that's bacteremia. And septicemia, they don't do very well either, so you don't sort of walk around and talk about it. As you mentioned, there's legislative requirements. Safe Work Australia has guidelines, and I've got a few references at the back. Queensland specific is Work Health and Safety Act 2011 and the subsequent regs, and it is a legal requirement both for employers and employees to maintain a safe working environment. And I've got a reference for that. Preventative measures, well, it's not rocket science. It's set out in these, how to manage it, but obviously you get rid of the moisture. That's important because the bugs don't like living in a dry environment that's not moist. You have ventilation, as you said before. If you have sufficient airflow, they don't congregate and therefore they don't stay. And certainly got to look in the ceilings or get someone to do it. You need routine checks, so they should be done on a, just like you test the lights for exits and your defibrillators and everything else, there needs to be an inspection program up and running, and it should be transparent. Mold resistant products, so if you can get away from using carbon-based and use other, not so much timbers, but, you know, basically substances that basically mold don't like chewing on. It might be plastic, it could be a rubber compound, they tend to resist it. And certainly if it's metal, stainless steel, fridges and that, the reason I use stainless steel is basically it might look good, but basically bugs find it hard to grow on. There's not a lot of nourishment in stainless steel. Unless it's rusty. And the other thing is I put here is employee concerns. So if they have concerns, regardless of how valid you may think they are, you need to acknowledge it. You need to assess the risk and then basically manage it. And that certainly means you have to be good at communication, because as we know, the module 101 of communication is communication, communication, and communication. And I see that as probably in half the call outs I've gone to for workplaces. Someone sent an email and they might have sent a letter to people or put it in their pigeonhole, and that's it. And, you know, that might have been good 40 years ago, but it's not 30, but it's not appropriate these days. So remediation is basically cleaning. So there are companies that do it. You need to utilise one of them. They've gone through a strict accreditation process. They will identify, they'll isolate it. If it's the kitchen, well, things will be out of bounds, staff get upset, but, you know, at the end of the day, to have to be fair and reasonable, you may have to develop plan B and have an alternative kitchen in the meantime, or decide that it's not going to be available. You've got to use PPE, so little paper mask, P1. You've got to, as these here, you've got to have non-porous clothing, appropriate footwear, and certainly eye protection. And as you can see here, you know, full face P3 respirator. Yeah, P2's under the legislation, but I think P3 is even better. Cleaning agents, there's a whole heap of things you can use. You don't listen to the media. Vinegar of 4:1 in water, clove oil, or bleach, good for non-porous. But at the end of the day, you can use the antifungal agents that some companies will advocate, but they have some toxicity. And basically, you want to use something that basically is low residue, appropriate, and cleans it so then people can facilitate it. So people don't use the antifungal agents because basically they sometimes cause as many problems as they're trying to solve. So you use what's simple and effective. And then you've got to dispose of it. So you can't just, you know, put it out the front and then wait for the garbage truck. So these people have to take it away, and it's got to be sealed, documented, and then disposed of appropriately. And as I said before, you've got to follow up. So therefore, you get the report, you go through that, they do the remediation, and then several months down the track, they come in and they do feather air, and they do a visual inspection, and they do air sampling and do surface, and basically prove that it's not zero. It'll never be zero, even if you clean it 4 times a day, because people always bring something in from outside, whether it's on themselves, their clothing, or their footwear, or the gear they're bringing in. But the thing is, basically, it's got to be lower, and it's got to be at levels that are acceptable. So managing staff, as we said, is really important, and it's really about risk communication. There are some staff who do get affected, and then it's an issue of they may need regular health checks, they may need relocation or redeployment because they can't work in that environment anymore, because they've been sensitized, a bit like those with formaldehyde and isocyanates, or 2-pack paint. You've got to find you may be employable, but you may find that you have permanent workplace restrictions, and for some organisations they can accommodate that, and for others they can't. So you've got to have washing facilities, and, you know, again, it's running water, soap, paper towels, got to keep your hands dry and clean. Good lines of communication, really from the top down. So you inform people, you keep them on board, you talk to them, not at them, and you take their concerns appropriately. And then if the evidence says otherwise, that's communicated too. Some people aren't happy after that, but there are some people who are very difficult to please, because, as I said, their perceptions, their reality, regardless of what the science says. Some people, particularly those that have been affected, need, as we mentioned before, they can't do remote work, or they can only do remote work from home, or they need relocation, or they need to change a role. And then basically, certainly access to appropriate health support, and certainly you've got to think of counselling and psychotherapy, because for some people the issue is not that they've actually been physically ill, but psychologically they believe they've been exposed and have issues with coping. So there are various booklets you can have. I just put up the one here from WA. It's 2015, I think, from memory. Things haven't changed a great deal. We've got, you know, there's a good reference material. I've put in the reference here from Work Health and Safety in Queensland, and that's accessible via the Work Health at Queensland site. They've got some good information. This is the American one. I just couldn't get a copy. The 4th edition came out 2 months ago, but I couldn't see one I could cut and paste. So that's the American National Standard Institute. I forget what IICRC Committee for Cleaning, Rehabilitation and something else, I think. And that's the peak body in the US, and the EU have another one. And as you can see here, there's lots of information, both from a federal perspective as well as a state perspective, and they're all pretty similar. So basically, when you've finished and you've done the cleanup, well then you will have identified the problem, you will have managed it and corrected it, whatever the underlying problem is. It's got to be complete. If it's not complete, then basically people will still have issues, and particularly odours may persist. So that means you've still got a problem if there's an odour there. So sampling, as I said, follow-up is important. So basically you've got to find and convince people that the bugs you've got are similar to what's outside, and that basically after you've remediated, if this is the outside level, this is the level inside. It's not zero, it's never zero, but it's a lot less. And the other thing is basically you've got to revisit. I've been given told to hurry up. So the takeaways, we've spoken about the types of mould, we've spoken about the factors that are conducive to mould growth. We've spoken about testing, both visually, odour and other more scientific methods. It does have adverse health effects. They are not common, but they do exist, and they should never be trivialised. They can be really difficult to diagnose and work out, because it's not like people come along with it written on their forehead. It's going to make life very easy. And there's legal requirements and legislative requirements, and we all have to comply, particularly if you're an employer or an employee. So I thank you for your time. I think the issue here is we need to be proactive, address staff concerns in a timely manner, and communicate. So thank you very much. And there's my references. I've only got a couple of questions here. This is from Melanie Lambert. She asked really good question. She said, what period of time of exposure would be significant, contributing to a diagnosis attributed to a person's place of appointment? I really don't think, and I did a bit of work on this, there's no easy answer. If they've got a pre-existing allergy to mould and they then work in an area, that could be that day or 2 days later. But for a lot of people with the allergic side, it comes on over months and even years, so it's very slow. And as I said, quite often it gets diagnosed as something else, and it's only after the event that people realise it's mould. I think the flip side is I see people that say, oh, I'm anxious and I've got asthma and it's due to mould. And then when you explore the worksite, there is no significant mould exposure. And basically there are other issues at the workplace that may not actually be physical. And it could be the work culture's an issue, or that basically that person sometimes is a round peg in a square hole too. But the thing is, for the infections, quite often they'll have a history of inflammation, be it the eyes, the nose, the sinuses, or asthma. And then, and as I said, it's not terribly common. You can get a pathological infection in your lungs, or I've seen one in the brain actually, which is very uncommon. Some rat poo, but it does happen. Usually it comes back to the diagnosis. So you need tissue, they'll grow it, they'll look for bacteria, and they find a fungus, and then you've got to sort of become a bit of a forensic detective to work back. So quite often that's 3, 6, 12 months down the track. It's usually at the end of the day go, oh, that was obvious, but it wasn't obvious at the time. So it's not usually where someone's well on Monday and on Friday they've got full-blown sinusitis, and particularly if they've got a history of sinusitis, the last thing we do is usually swab it. It's only with time. So the answer there is it tends to be quite variable, and sometimes there's not a lot of science until later. Sorry, that's the best I can do. Different moles, different latency periods. I've tried to look at this. There's no medical data on this. I don't think too many people have grown fungi in animals to test and see how long. They haven't done it in humans, one would hope. But yes, if it's like bacteria and viruses, there'll be different time periods. They may be anything from 2 days to a few weeks, but then basically it's then depends upon, is that the allergic component, which quite often you need to have repeated exposures before you become sensitized, as opposed to someone who's inhaled potting mix because their nose and airways are too close, have no PPE, and they quite often are sick. Usually within a period of 1 to 3 days, they end up in hospital. They have infections that don't respond to any bacteria or other treatments. Then people get a specimen that might be 2 or 3 weeks in the track. So those ones fortunately are diagnosed fairly early, but they're not terribly common. But yeah, in the main, I suspect a fair few of these, the issue of mould and fungi probably doesn't come up. And if it does, it's quite often down the track. I mean, the most common issue here is people see mould around a air conditioning vent or in an area on the wall where it's moist, or in the eating area or the toilet. And people, the hindbrain in humans, if you've got a bad smell or if you see something that's not very nice, quite often you've been exposed and you're sick. But as I said, exposure doesn't always equal disease. And the thing is, quite often there's a perception of illness, but when you examine these people and go from head to toe, and you look at the worksite, yes, the worksite's got a problem with mould exposure, but actually no one's got a physical illness or a physical condition such as an allergy. It's the perception of it. But that still needs to be managed, and quite often they're much harder to treat because people are convinced that they've been exposed, they're ill, and they're never going to be better. So it can be very difficult sometimes. So thank you for your time. I don't think I've got any other.
Yes, I've got a question actually from Andrew.
The voice, yes.
The voice in the background. How can an employer know if the mould exposure was sustained at work or away from the workplace?
Well, that comes back to getting a good history, looking and having someone probably look at the workplace, and then basically determining what the person's hobbies are. So that basically, some people might take that on face value. I've had it where people say, I don't get exposed to, and I remember one guy with lead, I only get it at work. And then basically, when we got his wife in, we worked out he made lead soldiers and did it in a shed with no ventilation. So I mean, that was pretty black and white. But so it was actually a non-occupational exposure. Actually, for him, it was an income, but it was self-employed income and not pertaining to his other employer. But I think this is a challenge, and if you suspect it at the start, you can probably go down that track. But the problem I see with a lot of these is they come in with what seems to be an allergy, and then there's a million things can cause that, particularly with asthma and runny nose and sore throat. And basically, then if they get a fungal infection on top of it, that quite often makes it easy. But that's exceedingly rare. They're usually secondary bacterial. And most of the ones I've seen are allergic, be it a teacher in a music room that's never cleaned, or someone who's working in a shed that got poor ventilation, that's actually an old shipping container being converted with one light and products that stay there forever. So basically, I think the thing is that having a worksite assessment by someone who understands the pathogenesis of exposure and illness is important. But it's a bit like being a detective. You've got to put the pieces together. I have yet to see anyone tell me that it's A plus B gives C. I get lots of people that go A, D, and F. But the problem is they've jumped a few steps and made assumptions. So it's probably not a great answer, but I think the thing is you've got to ask the questions. I see some of my compatriots and colleagues who just assume, oh, you're at work, it's all work related. Well, that may be true in some universes, but basically humans are very transferable in what they take and what they suffer, and some things from home come to work and some things from work go home. So at the end of the day, you've got to get a really good history. You've got to be thorough, and then on the balance of probabilities to determine, well, what's fair and reasonable. And that's not always apparent. problem is if you've got an I've had a few where it's been accepted workers' comp claim, not just in this state, in other states. And then when you go through the due diligence and they get an OC physician involved and an OC hygienist, you realise it wasn't a work exposure. Yes, it's been accepted as a work exposure, but there actually wasn't any work exposure of a critical value, or if it was so insignificant, it didn't cause the diagnosis. It didn't cause the condition that's been diagnosed. It's actually due to other factors. So I find it can be very difficult, and certainly the times I've been involved is it's usually when the condition or the problem's been there for some time. That's why I've had employers where they get one of the cleaners to wipe something and they wonder why it keeps coming back every 2 weeks, every 4 weeks, every 6 weeks, because all they've done is just clean the external exposure. And I mean, at the end of the day, people aren't stupid. They know that they can read, they can access the net. Some of them have rallies in health. So you've got to be ahead of the game and be proactive and consider your staff.
Dr. Cunneen, I've got another question from Andrew again. How long can you expect to have symptoms after the exposure of mould at work?
Well, I think that depends upon, one is how, if you've got an allergic exposure and you become sensitized, well, every time you go to work, you may have symptoms at the end of the day or after a couple of days. So in those people, they'll have it until they're actually removed from that particular building or the workplace and relocated. So how long are their symptoms? Well, that could be a long time. They notice that they go on holidays, they have 2 or 3 days from work. So that's why you've got to get an appropriate history to work out, is this occupational or is this actually due to other factors not pertaining to their employment? And occupational exposures, particularly if they're allergic, doesn't matter whether it's mold, whether it's isocyanates, lead, or whatever, there tends to be an improvement away from work. And certainly when on holiday, so you ask those sorts of questions and you try to tease enough pieces in the jigsaw puzzle. The problem for those people, if they continue to be exposed, they continue to have symptoms. They may not get ill, but they may not feel 100%. For those that have infections due to inhaling potting mix or rat poo or whatever it is at the time, all of which is very unsavory, and they get it in their sinuses, they get it in their lungs. Although, as I said, one guy had a mass in his brain, had a seizure. We worked out when they drained it, it was actually a fungal infection, and he got it from the rat poo in a store that was never cleaned or accessed. Is basically that basically could be evident within a few days, a few weeks, or it could be months later when you've got all the results and you put all the pieces together. They usually don't go back to that workplace. Some of them are really ill and don't return to work. The ones that do, obviously the employer's got to fix up the workplace. They need to sanitize it, clean it and remediate it. And quite often, if that's happened, if it's an infection, they'll be fine. If they've got the allergic response, there'll always be something there, in which case they may still develop symptoms. Therefore, they may have to be relocated or redeployed or find alternative employment.
Yes, Andrew has just sent through a further comment that this worker has not been at work for 18 months, nearly 2 years now. However, is still reporting ongoing symptoms.
Well, I don't know the ins and outs, but I mean, if you're away for work from 18 months and assuming it's not an infection, as in your sinuses, a fungal infection, documented an acute fungal infection in your sinuses, your chest, or in your brain or somewhere else, and if it, let's say it was a allergic exposure, well, then if you're not exposed and you've still got problems, something else is causing the problem, probably non-occupational.
Well, I think that's it. I've got all the questions. Thank you, Dr. Cunneen, for giving us this just over. We have run over time a little bit, but thank you very much. I've just got another message. No, that was just a thank you. If anyone does have any concerns with any workplace that you'd like one of our occupational physicians to come to site, we do offer a complimentary service for that. that would be just to come out and have a chat and see what's about. If you want a formal report, then that obviously comes with fees. But yes, if you have any concerns, please don't hesitate to give us. Dr. Cunneen, would you like to roll to your references just to let people see your last slide?
Oh, second last
There it is.
slide. Yeah, there they
Yeah,
are.
second last slide. So yes, Dr. Cunneen's done extensive research to give you today's presentation. We thank you very much for your time today, Dr. Cunneen, and of course, if anyone has any other questions, please don't hesitate to give us a call, and keep an eye out, because our next presentation, free health webinar, will be coming up soon. Our details will be sent out on social media very shortly. Thank you for your attendance today.
Thank you. Have a nice day. All the best, and thank you for your time.